What causes mid-upper abdominal pain? We call this region just under the breastbone and above the umbilical area. This area we call it epigastric area. Different types of pain can occur in this area. So the important thing is to know how to diagnose it and what are the diagnostic possibilities. So you have sharp pain, burning pain, or sometimes cramping pain in the epigastric or the upper mid-abdominal area. You can have several diagnoses. Most likely you have functional dyspepsia. You can also have gastritis, you can have peptic ulcer disease, or you can have gastroesophageal reflux disease. So it's important to understand the symptoms really well, what exactly is happening. Because sometimes the diagnosis is a little elusive, but with good description of symptoms and signs, we can come to a correct diagnosis and help you feel better. So if you are having abdominal pain in the mid-upper section of your abdomen and you also have some burning in the chest or heartburn, then the chances are you have functional dyspepsia or gastroesophageal reflux disease. Now let's talk about these for a minute. Gastroesophageal reflux disease is actually diagnosis you can make by taking samples of your esophagus, by doing endoscopy, where a very small noodle-like camera goes inside your mouth, looks inside the stomach and the little part of the small bowel and your esophagus, and it takes some samples, and then through those samples you make a diagnosis of gastroesophageal reflux disease, because in that you will find esophagitis. Now all of us, everyone regardless, has some reflux. We all have some acid come up from the stomach into the esophagus, but we don't all get esophagitis or inflammation or irritation or damage to the lining of the wall of the esophagus, because there is mechanisms. Our esophagus quickly clears the acid out because it does not like the acid, so it starts peristalsis, it starts movements and pushes the acid out back into the stomach where it belongs. Acid belongs in the stomach. So you don't get esophagitis. So we all have reflux at least once every hour, but we don't get GERD or acid reflux disease because our esophagus quickly moves the acid out. It's like you have a candle and you're playing with the flame. You can flick your finger back and forth through the flame and you don't get burned, but leave your finger there long enough and you'll know what it means to get burned. So that's the same thing. If acid exposure is not long enough in your esophagus, you don't get acid reflux disease, okay? So if you don't have acid reflux disease, but you have these same similar symptoms, then the condition is called functional dyspepsia. So functional dyspepsia are two kinds. One is the epigastric pain syndrome, where you actually have the pain, and the other is postprandial distress syndrome, where you have symptoms of a little bit of bloating and early satiety. What that means is that you start eating a little bit and you feel full fast. You don't get to finish your meal. You don't enjoy your meal too much. You're full right away in a few bites. That's called early satiety, or you get satisfied very early with eating very little. So those two conditions have different kind of management. So in that case, if you went to the GI doctor, they do endoscopy, and then we can tell you, okay, everything looks good. There is no acid reflux disease, but you have these symptoms, so let's try to treat them. Sometimes you can have in the duodenum, when you're doing endoscopy, you may find a little bit of inflammation in these functional dyspepsia cases. As we understand these cases more, the functional dyspepsia falls under the same category as disorders or syndromes like irritable bowel syndrome, or in young children, functional abdominal pain disorders. They all fall under a new umbrella now called disorders of the gut-brain interaction, or DGBI. That's a broad umbrella term now. So we understand that there is some between the first brain, which is our brain, and then the second brain, which is the gut. There is interaction disorders. They don't communicate well. So there is visceral hyperalgesia, which means your bowels become excessively sensitive and you secrete certain hormones and neurotransmitters and molecules, compounds that actually increase the stimulated nerves and give you the sensation of pain. So in the case of pain, then sometimes we use, like you use in acid reflux disease, a group of medications called proton pump inhibitors. They block the acid and the pain many times goes away. But there are other things, of course, that you need to do. There are lifestyle changes, right? So there are some sacrifices to be made. So alcohol, caffeine, fried food, chocolate, they are going to cause increase in your functional dyspepsia pain, the upper GI pain, and they will cause you more symptoms of dyspepsia. Frankly, understanding dyspepsia is some sort of indigestion for which people just take some Tums, Maalox, Mylanta, Pepto-Bismol, etc. But if things are not improving, you need doctor's attention and you need to sort these things out. Sometimes in endoscopy, you may find you have gastritis with H. pylori. The Helicobacter pylori is a bacteria that is associated with gastritis. It is also associated with peptic ulcer disease, and in very, very rare cases, some sorts of cancers of the stomach. So if endoscopy is done and Helicobacter pylori or H. pylori bug is found, it is treated with antibiotic treatments. There are used 2 or 3 different kind of antibiotics for a brief or short period of time, like 14 days therapy, and you also cut down acid a lot with these proton pump inhibitors. You must have heard of all these names: omeprazole, lansoprazole, Protonic, Prilosec, Prevacid. They are all strong acid-cutting medications. So that remains the upper mid-abdominal pain symptoms. Now, what else can do that? Again, if the pain is severe and you also start throwing up, then it may not be just plain gastritis or reflux. Little children throw up a lot when they have reflux disease. Older people, adults, they don't do that. But if the acid reflux disease goes on for a long time, another symptom pops up, which is dysphagia, which means swallowing difficulty or the feeling of food getting stuck somewhere. If you get that kind of a feeling that with meat, with bread, food tends to get stuck and you have to drink more water, or you find yourself chewing a lot to make small pieces and then put it in your mouth, or you're taking a long time to eat, that tells you that something else is going on and you definitely need endoscopy and upper GI, which is drinking a dye, barium, and looking at if there is any narrowing in your esophagus. Because if your acid reflux disease goes on for a long time, there is scarring. And the scarring leads to what we call stricture, which is the narrowing of the esophagus. That narrowing tends to hold the food and makes you get the sensation that food is getting stuck in your chest. So that needs sometimes dilations. We put a scope in with a little balloon. The balloon inflates and stretches the esophagus. There is another condition I have previously talked about, that if you have the same kind of feeling or dysphagia or swallowing difficulty or food getting stuck, you may have a condition called EOE. EOE actually is an acronym for eosinophilic esophagitis. What it means is that we have a kind of blood cells, the white blood cells, they're called eosinophils or EOs. They gather wherever there is allergy or inflammation, so they are in high numbers and they secrete different kind of compounds like histamine and other products that tend to create the inflammation or allergy reaction. That allergy reaction goes on in the esophagus, and if that goes on for a long time, that also causes scarring. So there is a difference between acid reflux disease or GERD and EOE. There may be some overlap between the two, but they are differentiated based on endoscopic sampling biopsy results. When we go in, we take small samples and we look at them under the microscope, and then we see how many of these eosinophil cells are there in your samples of esophagus. The microscope has a high power field. Every field we count the number of eosinophils and we call it, okay, this sample has 5 or 10 or 15 eosinophils per every high power field. So your numbers should be ideally in a normal situation 0. You don't need any eosinophils or allergy cells in your esophagus. But if you have acid reflux disease, you can have up to 15 eosinophils per high power field. This is an arbitrary cutoff. If you have more than 15, then the chances are you have this condition EOE rather than acid reflux or GERD. In EOE, sometimes the numbers are 50, 60, 100 eosinophils per high power field. And the esophagus shows special kind of features. There's furrowing, linear furrowing, and rings that you can identify with. The tissue becomes hard sometimes when you're taking samples. So you feel that. Or there is visible narrowing, then you need stretching of the esophagus with EOE. So in acid reflux, going on for a long time, you can also have strictures, and EOE, you can also have strictures. Stricture means narrowing. So this is the story about the upper GI, related to what we call intraluminal, which means inside the lumen or inside the bowel column, the bowel canal, the bowel pipe inside. Now, what are the causes of your pain outside the bowel? Outside the bowel, you have the gallbladder, you have the pancreas. If you're throwing up and it's significant vomiting, very bad pain, you may have pancreatitis or inflammation of the pancreas. Pain is again in the center, right below the breastbone and above the umbilicus, in the center. It can be very severe. Sometimes these pain with gallbladder and with pancreas pains, they radiate. What does it mean to radiate? The pain just moves around, goes to the back. In the gallbladder case, it goes to the upper shoulder or in the middle of the two shoulder blades. So you can have these kind of pain. Then certain blood tests are done. In the blood tests, we send amylase and lipase, the two enzymes secreted by the pancreas. If it shows significant elevation, of course you have pancreatitis. It's a diagnosis. And if you have gallbladder disease, then an ultrasound will quickly tell you that there are gallstones or the stones stuck at the mouth of the gallbladder or in the bile duct, and that's giving you biliary colic or severe gallstone pain. Everything is managed a little bit differently, but diagnosis is what's important. So the message is that when you have this kind of epigastric pain, which means the pain in the upper abdomen in the middle, and it's not going away with a little bit of lifestyle changes that you did, you're eating better, you're avoiding fried food and caffeine and alcohol, and you tried that and things are not improving, you had a little bit of Tums, don't wait on it too much. Go to your gastroenterologist, go to your primary care physician, ask them, can I have a referral to see a gastroenterologist? Plain and simple, okay? They cannot refuse. If you are armed with knowledge and you're asking the right questions, why should your primary care physician not cooperate with you? They will send you to a gastroenterologist, and the gastroenterologist may do an endoscopy. Don't be afraid of that. We do it in babies and little children. They come out of it. When they're done, they ask, why are they not starting? I'm hungry. So they don't even remember this. So you don't remember. This is a 15 minute procedure, and it can answer your so many questions. Do you have acid reflux disease? Do you have gastritis? Do you have EOE? Do you have celiac disease? So many questions are answered. And if it's normal, celebrate. Then you can just manage it with managing techniques. The lifestyle modification, a little bit of weight loss, eating right, for taking care of yourself, avoiding caffeine, alcohol. Those things are all going to be helpful in the long run. But at least you got the bad things out of the way. And if endoscopy is completely normal, you don't have other, ultrasound is normal, you have functional dyspepsia. So today you learned something about functional dyspepsia, and it's two categories or two different types: epigastric pain syndrome and postprandial distress syndrome. Postprandial means after eating distress. We have difficult ways of saying simple things sometimes in medicine. Welcome to the medical world. Thank you for joining me. This is Dr. Sal from Gut Savior. Please comment me or visit my website, gutsavior.co. If you need more from me, I can guide you. Thank you.